In this video, we'll discuss about chronic obstructive pulmonary disease, COPD. Chronic obstructive pulmonary diseases. Entire respiratory tract, there are 4 layers. Let's talk about trachea. This is the lumen. This is the lumen of trachea. So the lumen is lined by epithelial lining, that is mucosa. This one lined by epithelial lining. This one is mucosa. First layer is mucosa. This mucosa lining is pseudo stratified ciliated columnar epithelia. Pseudo stratified ciliated. This one is the ciliated columnar epithelium. So lumen is lined by mucosa, and the second layer, that second layer name is called as submucosa. Submucosa. Second layer is submucosa containing gland. It containing glands. This gland do the secretion. The secretion is presented, a moist secretion is presented, which is secreted in the lumen by all these gland. All this gland secreted. That's why lumen always wet. So that sticky substances is presented in the nose in the same form, in the same type of secretion presented in entire respiratory tract. That secretion is formed by these gland present in the submucosa. Coming on the third layer. The third layer name is called as muscularis propria. The lumen submucosa, this one name is called as muscularis propria. Third layer. Then outermost layer name is called as serosa. So first one is lumen, that mucosa, then submucosa, then muscularis propria and serosa. These are the 4 layers. Serosa have another name, adventitia. This one is the one more diagram. Before starting COPD, we known as collateral airways. What is collateral airways? This one is respiratory bronchiole. This one is alveolar duct. This one is the alveolar shock. So alveolar shocks connected with each other. So multiple alveolar shocks connected each other, and this is known as 4 of Kahn. So multiple alveolar shocks connected together. This one name is called as 4 of Kahn's. Alveolar shocks which each other, so there are known as interalveolar collateral. So this one name is called as 2 alveolar shock connected. This one name is called as interalveolar collateral. Connected alveolar shock with alveolar shock. So this one name is called as 4 of Kahn. The multiple bronchioles are connected with each other. Multiple bronchioles connected each other. Bronchioles connected with each other. It is known as channel of Martin. Branchioles with connected to another branchioles name is called as channel of Martin. If one branchioles is connected with one alveolar, it is known as channel of Lambert. Can you see this diagram? So first one is here alveolar shock, here one more alveolar shock. Both of them connected each other is known as force of Kahn. Then similarly one branchioles with connected to the another branchioles. This one name is called as channel of Lambert. Then one branchioles connected with one alveolar shock. This one name is called as branchial alveolar. So this one is channel of Lambert. Alveolar shock, force of Kahn. Branchioles with branchioles, channel of Martin. Branchioles with alveolar shock name is called as channel of Lambert. So we can say force of Kahn is interalveolar collateral. Channel of Martin interbranchiolar. Channel of Lambert branchial alveolar. Alveolar shock with alveolar shock name is called as interalveolar collateral. Branchioles with branchioles interbranchiolar. Branchioles with alveolar shock name is called as branchial alveolar. So let's start chapter COPD. What is COPD? What is the full form of COPD? Chronic obstructive pulmonary disease. There are various diseases. First one is chronic bronchitis, emphysema, bronchial asthma, bronchitis, and bronchiolitis. These are the various diseases: chronic bronchitis, emphysema, bronchial asthma, bronchitis, and bronchiolitis. One thing is common in all of them. That is obstruction. That's why these are known as obstructive disease. One more thing is common, they are chronic disease, none of them acute. So two things is common, obstruction and chronic disease, not in acute. But the things is what is causing obstruction and the level of obstruction will be different. All of them having obstruction in lower respiratory tract, but starting from trachea till alveolar shock. What is the extract level of obstruction? That will be different, and the pathogenesis of obstruction will be different. So COPD is the group of disorder, all of them chronic and all of them obstruction. But obstructions can be at any level. They will differ. The level will differ. They travel. That level is trachea till alveolar shock. Anything can be the level. So differentiate first one, how they will differ. The level of obstruction. What the level of obstruction? The obstruction is that as seen as bronchus, bronchioles. What is the level of obstruction? Then second one is age, which most commonly it occur in patient. So age of presentation. Third important things, etiology. Etiology are the risk factors Are there any risk factor for this particular disease? And the pathogenesis is how obstruction occur. How the obstruction occur. Then cross pictures under microscopy, then clinical pictures. Various form of COPDs first started with chronic bronchitis. What is chronic bronchitis? Chronic bronchitis is a common condition defined clinically as persistent cough. Clinically persistent cough. Dry cough or cough with sputum. Two types of cough. So sputum is known as expectoration. Sputum, cough with sputum is known as expectoration. Expectoration with expectorations on most day. How many days patient have? Most day for at least 3 months in a year. At least 3 months of the year for 2 or more consecutive years. Continuously 2 years, second year, third year, like that. Yearly one time they affected 3 months continuous. So out of 12 months, every year more than 3 months, the patient having persistent cough with sputum or cough with expectoration. So sputum cough with expectoration is known as chronic bronchitis. It is usually occur in male more than that age year 40 to 50 years male. So it is general way of definition of that chronic bronchitis. Next one is pathogenesis. Etiology is smoking. Smoking is the risk factor. Now, how smoking leads to chronic bronchitis and what is the problem? Where is the obstruction? It is COPD, so there should be obstruction. So, what is happening? Already we know 3 layer is presented: mucosa, submucosa, then muscularis profilia and serosa. We know that 4 layer is presented. Lungs used for respiration, but some people misuse and do smoking. The lungs are not for smoking, but some people do. They just smoke. When they are smoking, the smoke going inside of that lungs, so it reach here the trachea. So smoke irritate. Smoking is causing irritation in the wall of trachea, so it will causes irritation in the wall of trachea. That's why in submucosa, that submucosa having glands will respond as a part of adaptation. So they will increase in size and number. Increase in size and number also. So the gland in the trachea, they will increase size also, number also. What is the normal functions of this gland? This gland forms secretion. So since the gland number and size both is increased, so there is more and more abundant of secretion. More and more abundant of secretion here takes place. is formed. All of these gland that is accumulated in the lumen of trachea that is causing obstruction. So that causes obstruction. So what is the cause of obstruction? The cause of obstruction is over secretion by the gland. Over secretion by the gland. Why the gland is doing over secretion? They got irritated from smoking. So what is the risk factor is smoking, which leads to irritation of gland, which leads to as adaptation of gland, hypertrophic and hyperplasia. So submucosa gland increasing size as well as number. They do abundant secretion in the lumen, so that luminal secretion is forming obstruction, patient having difficulty in breathing. So what is the patient felt that patient tried to remove the obstruction back coughing. So patient constantly tried to cough, and during coughing he is trying to take the sputum out. The sputum is in here cough is the secretion of the gland, and he is trying to split that sputum like this everywhere, so that the respiratory trachea is cleared and he can do the respiration. So that the reason the sputum cough with sputum, it is persistent. So this one is the pathogenesis. So over secretion of mucosa due to increase in number and size of submucosal gland of trachea and bronchi. Etiology: smoking. Apart from smoking, non-smoker affected from it can be due to atmospheric pollution, it can be due to occupation or infection. Then crossly, that branchial wall is thickened. So that branchial wall become thickened. So multiple mucus plugs obstructing the bronchi. Microscopy. This is the difference between normal and chronic bronchitis. Microscopically, normal compared the 4-layer. Compare submucosa and mucosa. Both of them in normal of that lining is pseudo-satisfied ciliated columnar epithelium. These are red cell drawing pseudo-stratified ciliated columnar, but some cells are goblet cell. Some goblet cells are presented, that is normal. Normally goblet cells are very few number, but they are present. Submucosa, here submucosa, how many glands? Very few only, 3, 4, 5, whatever, a rough number of that gland. In this chronic bronchitis, mucus of both of them compare. Here and here you will compare. Third and fourth layer, no changes. Only first 2 layer, mucosa and submucosa only. The mucosa lining in chronic bronchitis, multiple goblet cell is presented. Here 1 or 2 only. Here multiple goblet cells are present. Here goblet cells increase in number. So this is known as this one is known as carpet cell. Hyperplasia, which is the pictures of mucosa and chronic bronchitis, that is carpet cell increases. Main difference will be seen in submucosa. See this submucosa, chronic bronchitis, if you can compare the gland increase. Okay, here increase. Gland increases in size and number. Count the number. There are more. Cannot see the size. It is increases that size. So gland, the size or number do not know. So here and comparing to submucosa, here gland and number will increases. No changes in third layer muscularis propria and adventitia. Third layer and fourth layer no different. No different between both layer of muscularis propria and serosa. What is read index? Read index is the ratio whenever there is the numerator, there is denominator. Read index is the ratio. What is the denominator? Denominator is the total submucosa thickness. Total submucosa thickness. Name is called as denominator. That is just denominator in both of them. But what is the numerator? Numerator is the portion of submucosa, portions of submucosa having gland. So this is A, this is the A part, this is the B part. Here A, B. A upon B. Can you see? This is A, this is B. A, the portion of that submucosa having gland. Submucosa having gland, A1. Then B. So A upon B is the read index. In this case normally, this case is normally in chronic bronchitis, total thickness is same, but the thickness of that portion which having gland increased. Here thickness of that portion which having gland, it is increased. So since numerator is increasing, denominator is same. So if we say total read index is increased. So what is read index? Microscopy of chronic bronchitis, read index increased. Read index is a ratio between two things. So read index, ratio between two things. Numerator is the thickness of the submucosa, mucous gland, that is hypertrophy and hyperplasia. The denominator is the total bronchial wall, so that is numerator, and denominator in chronic bronchitis, total wall thickness is same, so denominator is same, but the numerator mucosal gland thickness increased in size as called that numerator. That's why numerator is increasing, denominator is same, so total read index will increase, so that the change in submucosa, apart from it, goblet cells are increased in number. We can notice that goblet cell hyperplasias in this diagram. Read index can see this is the submucosa area, where the gland is present here, where the gland is present, this is the total thickness of the submucosa. This is the thickness where gland are present. This one is the submucosa. This is the total thickness. So what are the clinical feature? Most important clinical feature: persistent cough. The patient always cough, either the cough is with heavy expectoration. It is not a dry cough. Patient have abundant of sputum. Same time it may be throat clearing like this. Every time patient tends to do so because he is having abundant of secretion in the lumen and he is clearing the throat every time. So cough is the main symptoms. Sometimes the over secretion of mucus plugs are formed. They obstruct the trachea, so patients are breathing very difficult. So that condition name is called as dyspnea. Very difficult to breathe. This condition name is called as dyspnea. Then a patient feel difficulty to breathe leads to cyanosis. Cyanosis. Because of cyanosis, patient look blue color. That's why it is known as blue blisters. So this is the diagram of heart. Right side of the heart receive impure blood. Receive impure blood from SVC IC. All the impure blood coming to right article. From right article, pure blood goes to right ventricle. From right ventricle, where does it go? Impure blood. Impure blood goes to purification. For purification into lungs. And the lungs purify the impure blood. Deoxygenated blood and impure pure blood comes to the left. The pure blood comes to the left side. Now currently the lungs is having chronic bronchitis. Here it have chronic bronchitis. They present with chronic bronchitis. So these lungs will not accept blood for purification because the patient have breathing difficulty. Purification of blood will not be done. So all the blood will return to that right side, right heart. So it will be returned. It will not be able to come in the lungs for purification. So the right ventricle, there is more blood. So here more blood. That means leads to right ventricular hypertrophy. That's why a patient with chronic bronchitis present with right ventricular hypertrophy. So this is the reason chronic bronchitis is the right ventricular hypertrophy. This is the reason chronic bronchitis. It is a disease of lungs and it eventually leads to right ventricular hypertrophy. Right heart failure or right ventricular hypertrophy will be there. The right ventricular will enlarge in size because it containing more blood. So the wall of the ventricle will get thickened. So it look like big heart. You see it, look this heart of cow. So cow means cart. heart of cow. That's why it is known as core pulmonary. It is a heart failure in which heart enlarge in size, look like a heart of cow. It is due to lung problem that is known as core pulmonary. So right heart failure which takes place due to lungs problem, and the right heart is enlarged the size, the disease known as core pulmonary disease. So enlargement heart with prominent vessels. If you do the activity of such patient will find enlargement.